Hello, my name is Al Giant. I'm a citizen of Sun Prairie. I'm going to be moderating a short program with two experts in the field of medicine. We're going to be talking about the implications of cutbacks in healthcare in the state of Wisconsin as well as nationally. We have two physicians with us today. We have Dr. Laurel Mark, who is a practicing physician, and she will give you more information about her background in a second. And then we have Dr. Gene Farley, who is a retired professor of medicine from UW-Madison, and he will provide a little bit more background on himself before we get into some of the specifics that we have on this really important issue that will affect the lives and health of all of our citizens here in Wisconsin. So please, Dr. Mark, if you could give us a little background about yourself.
Hi, I'm an internist, which is a specialist in adult medicine, primary care. I've worked in the Madison area and southern Wisconsin, actually, since 1982. And I work for UW Health, and I get to have the privilege of traveling to a lot of communities in southern Wisconsin to help out in different clinics.
Okay, thank you. And Dr. Farley, can you give us a little bit about your well-known background here?
Well, I'm a family physician. I used to be a real doctor in rural practice in upstate New York, and then started a developing family medicine program at the University of Rochester, and ended up here in Wisconsin, University of Wisconsin, as chair of Department of Family Medicine here. But all my life, I've been totally aware that we've had to have universal health care. I grew up during the Depression, and it was obvious then that people needed health care. And we are the only developed nation that has ever failed to get that. And so we have the most expensive healthcare system in the world, and we rank 37th in the world for outcome. Those with universal health care, where everybody's covered, do much better. And any businessman who says we can't afford it doesn't know beans about beeswax, because we already pay for it. We pay more than any other nation in the world to keep so many millions of people uninsured.
Thank you. So we're going to have a lively conversation here. I can see that. I was going to say what you mean, but I think you are. Well, why don't we start next then with Dr. Laurel Mark, and then ask you, Dr. Farley, to add to it. Let's first talk about the implications in the state about the cutbacks that are going on in Wisconsin. Then later in the conversation, let's go to the federal level, national level, so listeners and viewers can keep that separate. I'll ask a general question, and then I have some specifics later. But Dr. Mark, what do you see as some of the likely consequences of the cutbacks that you see going on in Wisconsin for healthcare?
I don't think you have to actually speculate about the consequences, because we get to see them every day in the clinic. I do primary care, and I see patients every day I go to work. And what we have seen over the last few years, and particularly over the last year here in Wisconsin, is that the cutbacks in Badger Care, medical assistance, and the changes to the health insurance programs for government employees have made a huge difference in what we experience in the clinic. There are really two different parts of that question. The Badger Care, Medicaid is part of Badger Care. Badger Care includes that, plus a bunch of other programs. And the types of cutbacks that we've seen there is, first of all, people who lost coverage, who no longer have it. Secondly, extremely long waiting list to get coverage, even if you are theoretically eligible. So a lot more people now who are just waiting and waiting, and they don't know if they're even going to get it. The third thing is that there are higher copays for people who do have Medicaid, who do have Badger Care, and many more restrictions on what they can do with it. When you look at it from the outside, it looks like some of those increases in the copays are not very much. They still don't pay a lot, for example. It used to be they'd pay a few dollars for their medications, and now they may have to pay $10 for their medications. But the difference here is that if you're on Badger Care, you're pretty much desperately poor to begin with. It's very hard to get on Badger Care. So the difference of paying $2 for a prescription and $10 might really be the difference of being able to afford it, especially if you have sick children who need more than one medicine, which is the usual case. So there's that. So despite all of the, I see some ads that describe an increase in expenditures for Badger Care. In real life in the clinic, what we see are the cutbacks.
What are the, and I'm going to ask Dr. Farley to expand on this too, but you describe what's being cut back or the higher co-pays. When you look at individual patients, what are the consequences to these real people? Can you give a description without, of course, revealing anybody's name or
absolutely.
identity, like what's happening to individuals?
That is actually the important point here, because the other part of that, I'm going to dial back a little, the other part was the changes to the health insurance for government employees. That was part of that budget repair bill. Again, people are paying more in their premiums, more in their co-pays, and deductibles, which they didn't used to have. This actually translates to people having to spend a lot more money to get health care. Fair or not, what really happens here is that people don't get as much health care. And what we've experienced is when people call in and we give them advice and we want them to come in to be seen, a lot more resistance. People just don't want to come in. They have a higher copay when they come in. They have deductibles. It costs them much more out of pocket. It's a lot harder to talk people into that. Especially harder to talk people into going to the emergency room when they should go to the emergency room, because the copay there is $100, and that's a lot. And you have to be convinced that you really need to spend that. So we see people who are delaying care, not coming in, and then on a personal basis, what we do in the clinic now is a lot of negotiation. If you really care about whether your patients will actually be able to get the medication, do the treatment, do the tests, you have to stop and ask the question about whether they can afford it, and they'll do it. And you end up negotiating, spending most of the visit trying to find a way for them to be able to pay for it, or which is the most important medicine, which is the most important test. Now, that doesn't always translate to good health care.
Okay, great. Let me switch just for a moment here then to Dr. Farley. What are you seeing, what are you hearing from your colleagues about the practical consequences of these cutbacks in patients? If they're not getting the health care, what's happening to them?
I think Laurel has told you a lot about that, but I'm going to go back further because my wife and I were in practice before Medicare came in. And in those days, the charge was $4 an office call, if you could afford it. And if you couldn't afford it, we didn't charge anything. But we had a lot of elderly. It was rural. They were not rich. They were very unrich. And many people couldn't afford the $4. So we wouldn't charge them, or we'd charge them maybe $3, even 50 cents. But they were proud and responsible people. So they did not want to come in when they thought they were asking for charity. They were responsible, caring people, mostly widows, mostly poor. Some of them had been farm wives and everything, when they lost the farm and everything, and they had very little. And so that when Medicare came in, all of a sudden people were using us responsibly because they were responsible people and did not want to go in debt or did not feel they should be wanted to accept charity, which we didn't think it was. But now they could come in with a sense of pride because they knew the care was being paid for by us, the people, through our government, which is considered un-American by the conservatives, excuse me. But it made a tremendous difference for this group of elderly patients. And now as we watch, Medicare has gotten so the copays and the deductibles in Medicare are so much, partly because of the absolute way it's used. It's not done to make sure it covers everybody. When you cover everybody, you cover healthy people, unhealthy people, but no insurance company wanted us old geezers because we old geezers cost more. And but Medicare took care of that. Insurance companies did not want the poor because they have more illness load. So Medicaid could take care of that. But to take care of the population from whom insurance companies might make an investor profit, we could not have those covered. And so that I'm talking back, not looking to see who's been cut back. Laurel experiences that every day. I'm aware of it because people used to be calling us and complaining and asking how do we do it. And I still have people who find trouble finding a doctor who can see them, finding Medicare coverage. So that we have the most terrible system as far as getting health care to the people who need it promptly and easily and affordably of any nation in the world.
Okay, so let me speculate and then have you professionals tell me what's real. When I was younger, I had heard and believed that if you didn't catch a child's ear infection in time, it possibly could lead to hearing loss. Is that true? And then is that something that might be showing up or not showing up in a clinic because some mom can't bring the child in with the ear infection because they think they can't afford and don't know? Am I exaggerating? Is that a reality?
It's a possibility. Actually, I think the data does show that treating ear infections does decrease on a population basis. That means all comers, not any individual kid.
Right.
It does reduce the amount of deafness in the population. But the broader question there is people who delay care for their chronic medical conditions or even for an acute condition that they don't know whether it's serious or not.
Could you give an example of an acute condition?
Absolutely.
Yes.
In fact, one of the heartbreaking things about being a doctor these days is if you really listen to people tell you their stories.
Yes.
Every day is filled with sad stories of people who have delayed care or not gotten it because they can't afford it. So I'll tell you, I always tell people, if you follow me around and look at my schedule, I can tell you an insurance story or a sad story. So here's the one of yesterday, okay? Just the one of yesterday, is I saw a woman who actually does qualify for Badger Care, and so she was in for the first time in 7 years to get, she's a woman in her late 50s, so she should be getting Pap tests and mammograms and pelvic exams, and she was in for the first time in 7 years because now she can afford it. And the real reason she came in besides that, because she can afford it, is because her sister, who is 1 year older than her, just got diagnosed with ovarian cancer, which is frequently fatal. And her sister actually had symptoms for about 2.5 years. And actually her sister's a few years older now that I think about it. Her sister waited until she was eligible for Medicare, which is age 65. And until that, she was afraid to go in because she could not afford it. So of course, by the time her sister goes in to be treated, once she gets her Medicare, it is metastasized, it's far advanced. So who knows whether 2 years ago, chances are, she would have been curable.
And speaking of early detection, one of the things that, if I read this correctly, was cut in Wisconsin because of some political concerns, was a cutback in screening for breast cancer and a cutback in screening for cervical cancer. I read an astounding piece of data the other day that 1 out of 8 women in their lifetimes will incur breast cancer. So if I could start with Dr. Farley, can you confirm that information is generally correct, or fix it if it isn't? And what are the consequences if we have thousands of women not getting the screening for the breast cancer and cervical cancer, as was cut back in Wisconsin?
I can give you my impression.
Please.
Because in '56, when I entered practice, that was in the Public Health Service on the Navajo Reservation with the Navajo, we never saw a cancer among the population we were caring for, cancer of the breast. When I entered our rural practice in upstate New York in Trumansburg, I had one cancer patient, one person with cancer of the breast. Was I missing a lot? I hope not. And now cancer of the breast is so common. So either we're detecting it more or there is more. I think there is more. So that, and it is, if you can't afford to pay for it, no insurance company wants you if you're going to cost them anything. If I, as I say, I'm 85, so I'm lucky, I'm covered with Medicare. But if I didn't have Medicare, if we didn't have it, no insurance company would want me. I couldn't afford to pay whatever they'd want to so they could maximize their profits. And so that let's go back 58, say I was 58 and had a pre-existing condition, no insurance company would want me because their responsibility, if I'm a CEO of an insurance company, my only responsibility, and Milton Friedman reinforced this when he said, A CEO of a company has no social responsibility other than to maximize profit for their investors. So if I'm a CEO of an insurance company, if I don't look good on Wall Street, you get rid of me. They don't give a hoot whether I care for patients. I should not care for patients who have the need. So pre-existing conditions are a killer. And we successfully increased so that we have some of the highest death rates of the developed world in some of these things that other countries diagnose early and treat early because we refuse to cover them, or we let them go bankrupt, or they're responsible. They're not going to go bankrupt, so they don't get the treatment.
So let me ask you both a blunt question and start with this response from Dr. Mark. With the reduction in the breast cancer screenings, which I understand is thousands won't be done now because they do not have nearby alternatives. They have to drive a county or two away. Poor single mom may not have a vehicle or time to get 60 miles to a place.
That's true.
Are we looking at women dying prematurely, not making that 5-year survival rate?
Oh, I think that's undoubtedly true. I think we should be clear about what happened here, too. There was a reduction in the program itself. Mm-hmm. There is a program called the Wisconsin Well Woman Program. Okay. Very bare bones program that provided breast cancer and cervical cancer screening and one other minor thing. And you had to be really desperately poor and not on Badger Care to qualify for it. So you were talking the most vulnerable population. What the current administration, what the Walker administration did was pass a rule that took away the funding for Planned Parenthood to provide those services, or to provide any service. And in some counties in the state, Planned Parenthood was the only provider of those services, so there's nobody else to go to. That's how you get to these long drives to someplace else. Undoubtedly, there's no question that without coverage, women do not get those screenings. In fact, nobody does prevention without some coverage for it. We're just not smart enough as a species to be able to look forward 10, 20, 30 years and do all the prevention we need to do. And so cutting it back, I think, undoubtedly will cause that. There's another problem with that, though, too, which is how was that rule made? That rule, that change, was not made with public hearings and a change in the law. The Wisconsin legislature did not vote on that because the Wisconsin legislature last year voted to allow the Department of Health Services, which is an appointed position from the governor, to make all the rules for Badger Care and Medicaid without hearings, without any public knowledge. So they can change laws, they can change those rules from Monday till Tuesday, they can change eligibility, and there's never a hearing about it. All that happens is the Joint Finance Committee has to vote up or down on them.
Let me ask.
So that's a huge problem, that the public doesn't even know whether you agree with that particular thing about any of the changes that are coming.
Here's another consequence question, and Dr. Farley, if you could pick up on this, and as well as a comment that Dr. Mark just made. From what I've read, that a breast cancer that's detected early enough, the survival rate for 5 years is above 90%, and that if it gets into later stages, the survival rate drops down to only 25%. Are those valid statistics?
Yeah, they are valid statistics, but we have a question with all cancer statistics, and I'll use my wife as an example, who died 3 years ago from cancer. If her cancer had been discovered 5 years earlier, and she lived those 5 years, she would have been considered a 5-year success rate in preventing it. But with no interventions, because it wasn't diagnosed till 5 years later, so she had 10 months. So we don't know a lot about cancer. I mean, how long? That's why insurance companies don't like to insure people who have cancer, because they may have had it for a long time, slowly growing, no basis for diagnosis, then diagnosed, and then once it's diagnosed, then we talk about survival rate. But when I'll use my wife as an example, did she have a 5-year survival rate, a 10-year survival rate, a 10-month survival rate? According to statistics, it was a 10-month survival rate after the cancer was diagnosed, but it was far advanced. So this is always a problem with cancer. We know, though, that we can reduce the number of deaths with early diagnosis of most cancers. We can never say that the person's totally free. That's why insurance companies, if somebody has had a cancer, insurance companies do everything they can not to insure that cancer.
Okay. So, Dr. Mark, on the statistics, am I reaching a reasonable conclusion that cutting these screenings, given this survival rate or non-survival rate, has real
Absolutely.
consequences?
The purpose of screening, we don't screen for everything. We screen for the things, if we're doing a good job, that early detection would make a difference. So there's really, I always tell people, there's only 5 or 10 things maximum that you ever want to screen for, because right now we don't have a way to make a difference in some diseases. But breast cancer, absolutely. Cervical cancer, without question. The change in the survival rate of cervical cancer is
Fantastic.
fantastic. It's a huge success of modern medicine.
To catch it early.
To catch it
Yes,
early and cure it before it goes anyplace else. There are a few other things that are
Such
like
as?
that. Cholesterol. Doing a test for cholesterol has actually been shown to make it, if you control cholesterol. Blood pressure is probably the best case right there, because most people cannot tell if their blood pressure is high. And control of blood pressure absolutely lowers the chance of having a heart attack or a stroke.
So if your patients or would-be patients fear they can't afford it, they can't get badger care, things are cut back, you don't get in. This is an
There's
easy.
no question about it. There's a lot of data that supports that. Without covering prevention, people do not go in and do that. Without covering screening, rather, they don't go in and do that. And without being able to afford healthcare, people don't get the services.
And screening is different than, in other words, if I examine a patient and suspect that she may have a cancer of the breast, that's no longer screening. That's really trying to confirm the diagnosis. But if there's no reason to suspect that she has it, then I screen, and that's where you get it before we even suspect. So it's different. Screening is to identify before anyone suspects it. My doing studies after I suspect it is to confirm or disprove the diagnosis. So,
Do you have other observations about the consequences of the cutbacks at the state level, and then we can look at the federal issue next?
Sure.
What jumps out?
Office visits are very interesting now. It's been changing slowly, but really took a dramatic increase this year. A lot of times when you call your doctor and you have a problem, they'll write down that you're coming for that one problem, and your doctor wants to stick to that subject, right? Sinuses, allergy, whatever. The most typical thing people say to me now when I walk in the room is, this copay, this cost me, $35 or $50 just to come in. You're going to take care of all my problems today. And they give you a long list. I don't blame them one bit, and I sit there and do it. But I know for some of my colleagues, it's very hard when they have a full schedule packed with people and and they don't have that much time. So you're either not getting your problems really taken care of because you don't want to come in and pay a copay every single time, or the doctor gives it very short shrift because there's no time to take care of it. And this is real. If you really have to spend that much money every time, you're not likely to come in as much.
What are the public health consequences of not catching, let's say, kids with infectious disease, maybe just some kid with pink eye? Can you give your observations if they're not coming in, they're not catching, what bugs are getting out into the public more often because they're not getting into your offices?
Go ahead.
It's astounding to me that there's anybody who thinks that we don't need universal health care, because everybody goes out into the world and has to deal with other human beings, and that's exactly the problem, is people who go to work sick. They have to go to work. They can't get in to get any health care. So what are they doing? Is spreading their disease to everyone else. I have lived in other countries in the world in which you don't dare go to work sick because no one wants to get pink eye or a strep throat or pneumonia or flu. But here, it's par for the course.
And I'll use tuberculosis as one disease, because if I'm homeless and I'm sick, where do I go in the daytime? I go to where I can sit and read or do something. I go to the libraries, I go to the city hall, I go to the places where there's some shelter. but I can't get health care. And a real case was one where one who was in the men's shelter in Madison and was sick. They did everything they could to try to prevent him from having to have, excessive costs. And finally, they did get him into the hospital. And as the doctor described, he had TB out of every orifice. But in other countries, that'd be taken care of. In America, we can affect each other successfully.
Well, we have about 5 minutes, and I'd like to ask your thoughts on a national level. And you started to get into, do you identify some of the consequences, real people getting really sick and having long-lasting or death? What are some of the options that you think are practical and doable to change state and federal? And maybe we can start with Dr. Farley and then with Dr. Mark.
Well, since we already spend the money, so don't let anybody tell you we can't afford it. We spend more than any other nation. Now, we may pay lower taxes for health care, but we don't. We pay huge amount of taxes health care for old geezers like me, for Medicare, for Badger Care. Out of tax money, we pay more than any other nations that cover 100% of the population. But then out of our pockets, with our co-pays, our deductibles, our premiums, we end up paying twice as much. But Americans are proud that they're
So how
not
would you
taxed.
fix it? What would you change?
I would make sure that everybody's covered. No such thing as somebody who doesn't have high-quality health care coverage. I'd make sure that we had a payment system that got the insurance companies out of it. There needs to be no intermediate profit made from health care coverage. And I use England, which has a different system. That's a system where the doctors are employed by the government, by the healthcare trust. I'll use Canada, where the doctors are in private practice and paid by the trust fund. But everybody is covered. There's no such thing as somebody not being able to afford to come to the doctor. And we can do it. And I'm going back, but Teddy Roosevelt first introduced the idea, and I think it was 1906, so well over 100 years ago. Unfortunately, by the time Congress got to decide it, we were at war with Germany. And of course, it was a Bismarckian approach, and we couldn't be like Bismarck. That was German. And then, of course, when Roosevelt first suggested it, this is now Franklin Roosevelt, when Truman suggested it, when Johnson suggested it, that was communistic, because we couldn't be like communism where everybody has health care coverage. We have the best resources in the world. We have fantastic educational resources. We have spent fantastic amounts of money. We train good doctors, good nurses, good physician assistants. The healthcare system we have, the resources we have, is as good as any nation in the world. The way we use them is a disgrace to the nation, because we're paying for making sure people don't get good health care when we have the resources. And we do have the brains. We have to have the political will. And my bias is anybody who's running for office and says we can't afford it, they should be asked to name those people who could vote for them who should not have health care coverage.
Well, at 85, you have a very clear voice, a very clear mind. And I think
well, I find playing the angry old doctor helps.
Okay. Dr. Mark, what would you do to make it better in the state and national level? If you can give us your summary on that.
If I got to make the decisions, I don't think it's politically viable right now, but someday it will be, and it will be if we all work together. We really do need to cover everybody. One of the things that is very scary about what's going on now is we are rapidly moving to a system where we have multiple tiers of healthcare, where some people do have the ability to access all of the kind of wonderful care we have here, sometimes too much of it, sometimes not appropriately. Some people have no ability, and some people have limited. And we will end up with a country in which there's haves and have-nots throughout the system, and this will affect all of us. We really do need universal health care. I think we need a single-payer system. I think there's lots of ways of getting to that system, in which you could go to any doctor or any hospital you wanted to, and we were paid in a rational way. This will require us to get rid of the for-profit health insurance companies that do nothing but just take money out of the system for stockholders and not for health care. And there's many other places in that system. And it also requires that as physicians, we change our practice to be more attuned to what is actually useful and efficacious, and not just what makes money. Everybody is gaming the current system. there are a lot of different proposals out there, and there's a lot of models for improving how we do healthcare so that what you actually get has some value to it. And right now, all of the incentives, most of the incentives in healthcare are for profit at different levels, not for good care.
Thank you. Thank you. We've run out of time, and I want to thank you for listening. I think Dr. Mark and Dr. Farley have made it really clear what are the issues. You get to decide. You get to decide what kind of future we're going to have. And I hope that you think about it and contact your representatives in public agencies and public legislatures and help guide this decision. Thank you.